Good morning again. Okay, I'll give you a little background about my career in bereavement. I've been a nurse for 30 years, hard to believe, for me at least. And this is the first place I came to work. I worked in the adult med-surg area 30 years ago. And on my second night of orientation, I was taking care of a patient with a brain tumor. And she spiked a temp to 106.7, and before we got a cooling blanket, she passed away. And my preceptor looked at me and said, "Gee, Fran, I hope this is not an indication of how your career is going to go." But in fact, it kind of was. So I have always been interested in the psychological and emotional aspect of nursing care, as well as the physical aspect of nursing care. And so I love being a nurse, and I think nurses are very lucky to be at the bedside, actually hands-on, and actually making a difference for families, teaching them how to be families. So neonatal and perinatal comfort care are medical and nursing courses of treatment. So the goal is no longer cure, but comfort. And one of the beauties of comfort care is that it is kind of simple. The ideas of warmth and hydration, of bonding, of symptom management can be extrapolated to any population. It doesn't have to be babies. It can be a 95-year-old. And in fact, should be, because we spend exorbitant amounts of money, particularly at the end of life, in intensive care units, keeping people with multi-system organ dysfunction alive. And so, again, it begs the question of what is the point of what we're doing? What are we trying to do? So comfort care is something that can happen across the lifespan. It's also important for us to acknowledge our own personal attitudes about dying. And there's nothing like a death to bring out pieces of ourselves that we never knew existed, just like birth. So people who don't claim to be religious are suddenly having a bris, or they're having a christening. They don't go to church, they don't go to synagogue, but that they wanted to do. And you will see the same things around death, that many of the traditions that perhaps they have not been following have meaning for them and importance to them at these times. It's also important for us to have a kind of a handle of how do we feel about death and dying? How do we view that perspective? And as nurses, I think one of the things that we're lucky about is that we look at life as, it begins, it's lived, and it ends, and that's normal. How and when is the difference. But we're there to support that patient wherever they are at that time. And staff should try to be a source of stability and calm. I remember in my training, one of my professors saying to me, "Fran, I don't care what you say, I just can't see it on your face." So if you walk in and Mrs. Jones has a gigantic bed sore and it's to the bone, you're going to look at her like she's sitting in a bed of flowers. And I thought, okay, if you say so. But that it does help to have a poker face of some sort. The other thing is, in the midst of the moment, especially if it's the moment when a baby is dying, if we're running around and we look nervous, imagine what they're thinking. And the first thing they're thinking is, am I doing the right thing? Maybe we should do something. Get the embu bag. No, we have to be calm, we have to be supportive, we have to be present. So particularly for us, and I think in this institution, one of the things that's been very helpful for us is we have two postpartum floors. One is the well baby nursery, moms go there with their babies, and the other is really the high risk antepartum unit. Now they also have the mothers of our babies that come to the NICU, and now they've been helping to take the comfort care mothers. Now, as you can well imagine, how many postpartum nurses do we have here? Any? Okay. As you can well imagine, asking postpartum nurses who are used to taking care of nice, healthy babies to now expand their scope of practice to welcome babies who might die on their shift is a lot to ask. And I'm very glad to say that we are seeing a change in the culture there. that they are recognizing the need, because it's about the patient, it's about these moms, it's about these dads, it's about these babies. This is why we're doing this. So you're going to provide routine postpartum care, and whether the baby comes to us in the NICU or goes to postpartum, we want to teach moms and dads, we want to empower them to care for their babies. So with some of the babies that have actually survived to go home, we've taught mothers and fathers how to do little syringe feeds in the side of their mouth, or adaptations that Michelle has done for some of the patients. We teach them how to do that, because feeding a baby is a big deal in mothering. And so is changing your baby and bathing your baby. It's all part of the whole experience that moms are looking forward to. So we encourage family involvement, and that doesn't just mean mom and dad. It means siblings, it means extended family, it means close friends, if this is what the family would like to have happen. A very big thing I think we need to do is prepare moms for engorgement, because if their baby dies right after birth, they're still going to get engorged. And I think it is an injustice to them if we don't warn them about it, because just imagine, 2 or 3 days down the line, they're suddenly in agony. They wake up, their breasts are engorged, and they're like, oh my God, it's just one more reminder of my loss. I like to make a spin on that a little bit and say, you will become engorged, but it's one more badge of motherhood, one more proof that you are a mom. And just try to change the perspective a little bit. Pain management for mom is important. If she's had a C-section, she's going to be uncomfortable. So she needs to have pain meds on board regularly, and it's okay. And she can still pump and feed her baby, or put the baby to the breast. Hopefully that will happen. We had a baby recently, trisomy 18, who, when she was first born, was very irritable, kind of cranky. I tried to get her to suck my finger. She was not interested. Mom was nauseous, couldn't hold her right away. So the family was all holding her. And then mom felt a little better, took the baby, and about an hour later said, I think she's hungry. I said, great, let's see if she'll go to the breast. And this teeny little thing, she got on the breast like she'd been doing it forever. And mom was so happy. So happy. I then actually gave her about 5 cc's of formula. Now, this baby lived about 12 or 14 hours, and I promise you that the mother's memory of that baby latching on will sustain her forever. She will never forget that, and she will be forever grateful that she got that opportunity. Not every mother does. And we need to have referrals to social work, to child life, to the chaplain. As Dr. Paravicini said, this is a team effort. It takes a village, believe me. And no one should try to do this alone. It can be overwhelming and, frankly, a little intense, kind of sad. We have to have a way to debrief with each other. And no one knows what we do like other people that do it. And it's like parents. We run a memorial service here every year, and I've had mothers and fathers tell me, I come because this group of people knows where I'm at. They know what I've been through. I can talk about my child freely. Mom told me I was down at the playground with my kids, and you meet a new mom. Oh, how many kids do you have? And in my head, I'm thinking, do I tell her I have 3 kids but 1 died? Or do I just say 2, and now I've betrayed that child? It's pretty intense. She goes, then sometimes you say, oh, I had 3 children, my 1 child died, blah, blah, blah. And they get glazed, and they know, I've stepped over the line. They can't handle hearing this. So we allow a freedom to families because we're acknowledging what's going on. We are present, and we are allowing them to talk, and we're also modeling some behavior, I hope, for them. So what should you do? Breathing is a good place to start. Take that deep breath before you go in their room, because I know as everyone has done this and you do it for the first few times, you're like, am I ready to do this? You want to be in the right frame of mind. And then you do it, especially for nurses, we do. Now, one of the difficulties, again, with comfort care is, we're used to things being very regimented. This is the blood pressure. Oh my God, this isn't normal. This is what I'm going to do for it. Here's a temp. That's not what it's supposed to be. I'm going to do this. We like things very orderly. So comfort care is a little messy because there's no template. per se. And we might have to think out of the box. And we definitely individualize it from family to family, patient to patient. So it throws us off our game just a little bit. But I'm telling you, you have all the tools needed to do it. Smile. These families, believe me, often when they come to see Dr. Paravicini and I, we do our prenatal visit, and we say congratulations, they look at us like we have two heads, and not separately. They're shocked that anyone would congratulate them, but we're saying this is still a gift. This is still something wonderful. Enjoy this pregnancy. Right now your baby is safe, and that's part of the experience. All mothers, from the day they know they're pregnant, change the way they think about themselves. They are now thinking for two. And the relationship begins because they start thinking, what will my baby look like? I'm going to do things differently than my mother. We all say it, but we don't do it. And, I might have the next president of the United States. So the relationship begins very early. And that's why we also have to know that grief is not related to the length of that pregnancy or the length of the life. Because not only have they lost that child, but they lost all that they hoped this child would be. So ask if the baby has been named, and then use that name. For our Orthodox families, if it's a boy, they're not going to name the baby. Sometimes, though, they may have like a little nickname, and you can ask about that. Otherwise, you refer to the baby. Can I do anything for you and your baby? You come in. Hi, I'm Fran. I'm here to take care of you and your family today. Anything I can get you right now. Let me take a look at the baby. Have you opened up the blanket? Have you gotten a chance to feed? And you start doing all the things that you would normally do in a postpartum setting. If it's up in the NICU, I'm going to come in and let them see what the equipment is like and what we're doing. Why am I doing certain things? The NICU, we're a little bit more fastidious about certain things. So we have to, and that's a big, for my NICU staff, it's a big jump to switch from intensive care to comfort care in the NICU. You have to really stop and think about, what am I doing? Why am I doing? Tell a nurse not to do a dextro stick, but the baby's not eating. It's okay. But they're not eating X number of cc's per kilo per day. Exactly. We're not feeding these kids to grow. We're feeding them to make them feel good. So whatever they want is whatever they need. So anticipating the needs, again, tissues, water, cameras. Some of the pictures I'm going to show you were taken on my phone because the family didn't have a camera and we needed to get these pictures done. And so mostly everyone has a camera phone, but you'd be surprised sometimes they don't. We do have actually a 35 millimeter camera also that we use, and that can be downloaded onto the computer. We can send pictures to families, or we can print them. Do they want clergy? And this is something that I think is extremely important. It's something that Dr. Paravicini and I explore prenatally, is what's your spiritual foundation? Would you want clergy? Would you want our chaplains? Whether or not they want family. Do they want to be just the two of them? And sometimes parents need a little bit of time. Just the couple with the baby, and then they'll ask for family to come in, including their other children. Being present, and I just don't mean with your body in the room, but being present is about being there for them, about them recognizing that I don't have to be doing something every minute, but I'm here. All right, I've done what I need to do. I'm just going to go check on my other patient. I'll be back in about 20 minutes. If you need me, you can call. I'll come right away. So that they know that they're supported, that they're not left alone in the room, that someone's going to be there. In labor and delivery, they're going to be with the mom until the mom goes down to postpartum. But postpartum, and even in labor and delivery, you may have more than one patient. Remain available. And so you got to be in there. And I know this can be uncomfortable, but you got to show up. And you have to, when you say, I'm going to be back, you have to be back. And if you can't be back, you have to send somebody else to go in there. Jane got caught up with her other patient, but she asked me to come in and check on you. Just want to see how you're doing. And remember, you are experts in what you know and in your field. And families, they're not looking to us. They're not going to say, Fran, what's your expertise in bereavement support? I showed up with a glass of water. They think I'm great. How can I prepare the parents? So it's taking time to explain what we're doing and why we're doing it. This recently happened to me. We had a baby that was diagnosed with a huge facial mass. And in prenatal pediatrics, the discussion was about whether or not this child could be delivered, if we would do an exit procedure, which is where they deliver just the head and intubate before the rest of the baby is delivered, whether surgical intervention after the baby was born was appropriate. And so there were many, many different experts involved in trying to figure out what was going to happen with this baby. And in fact, one of the surgeons shared with me when I talked about we were getting ready for comfort care, just in case this mom wants to hold the baby, and she said to me, "Why would a mother want to do that?" And I said, "No, doctor." And she said, "I don't know why I said that, because I've had a loss myself. And thankfully, the doctor made me hold my baby." So you never know what people are living with and dealing with, and what motivates them or is in their closet. And so we can't assume certain things. And just because we're professionals and we're trained, just like I said before, we all have our own issues about death and dying, what we would do, what we wouldn't do, how we would approach, how we wouldn't approach. So we have to keep that in mind and give ourselves a little space. It's important for us to let families know some of the physiological changes. So the baby that I was talking, I think I mentioned her already, who lived 12 hours. When I went to see, I saw that baby the night she was born. She latched on, she looked great. When I came in the next day, her color was different. So immediately I said to Mommy, "Her color looks different to me. Did you notice that?" And she said, "Yeah." And I said, "So it could be that her body is starting to shut down." She was like, "Okay." Now, it's sad. I hate to say that to her, but I also don't want her to think I'm not paying attention, and that I want her to know this is going to be the course of this child's life. This is how it's going to be. And for this baby, this is normal. When I went back, and we're going to talk about this case later today, the baby did die in the presence of several of us and in Mommy's arms. And we're going to talk about what that was like. So they're going to see changes in color. They're going to see changes in breathing patterns. Often these kids breathe a little faster than the average bear, but they don't breathe real deeply. Now, sometimes they breathe like any other baby, but then down the line they start to go into failure. They're breathing a little faster. Their color starts to change. They can't eat as well. Again, we have to normalize the fact that that is the expected changes physiologically that this baby's going to have as part of the dying process. But they are not in pain. They actually go to sleep, especially as their circulation gets poorer and poorer, their carbon dioxide levels rise, they go to sleep. They may have decreased movement. There may be some gasping. Now, I will admit that sometimes we've given morphine because gasping can be a little hard to watch. They're not really in pain, but we can reduce the amount of gasping, and frankly, it's for our comfort at this point, I think, and also comfort for the parents. But again, we want to talk about the baby is not doing this because he's thinking, "Oh, I can't breathe." This is automatic, so that they're not suffering. That needs to be brought to them. The other thing that we need to do is describe obvious anomalies. The slide that I'm going to show you next is a little graphic. It's a gastroschisis. And the reason we take some of these pictures is that parents in their mind, can't imagine, what is a gastroschisis? What do you mean the baby's intestines were born outside of its body? They can't, they're like kids that way. So, the boogeyman is, 85 feet tall, when in fact it's not that bad. But the other thing, this is pretty graphic. A mom can see without any doubt, wow, of course my baby couldn't survive. Who could survive with this anomaly? Now for cardiacs, this is always a little bit of the difficulty because most of these hypoplasts look perfectly wonderful. And parents, I will tell you, because every parent, I will guarantee, is also praying that we're wrong. They are praying that we had a misdiagnosis. We had a hypoplast that we thought would, live 7 to 10 days like they usually do, and 5 weeks later was still alive. She came back, she was in failure, and she died within a few days. But, the family thought, what happened here? So we're really not great at predicting when exactly a death will occur. The other thing that I think that Dr. Paracchini and I try to concentrate on is that we're following your baby. Your baby leads us. So if your baby comes out kicking and screaming, great, we're going to go in one direction. And if the baby comes out very weak and unable to do certain things, we're going in a different direction. But we're going to welcome your baby no matter what. And we also discussed the fact that some babies will not survive delivery or survive the pregnancy. Now, we had a child a few weeks ago where exactly that happened. Baby had a very large tumor on her back. It was discussed again in prenatal pediatrics. Decision made that they would follow the mother, follow the baby's progress, and deliver by C-section at the appropriate time to do a surgical intervention. Mommy came back a week later, and the baby had developed hydrops and had died in utero. They were so shocked and so unprepared that as we did our usual, talking to them, would you like us to bathe the baby, do a memory box, they were very hesitant. And it really showed us how important preparation is for these families. They need to take all this in and kind of let it filter out and process it all. The other thing that happens is, as I'm sure all of you know, when you give bad news to somebody, they heard like the first 5 words you said, and now they are everywhere else. So things must be repeated. And families will say, oh, I never heard that before. Oops. And you have to say, yeah, we did. We talked about this, but you were very anxious, I'm sure, and I will repeat it. That's perfectly fine. So we need to reinforce what we're telling them. It's also why it's so important that all of us are on the same page, that the things I'm saying or what the doctors are saying is what the social worker is saying, what the child life specialist is saying, because we all overlap. And that hopefully gives a message of cohesiveness to the families. Wow, these guys really know what they're doing. Everybody's kind of trying to do, the same thing. And they're helping each other. So that also makes us look good. We're working as a team. Did I go back? Oh, no, I didn't. Okay, so we're going to see this next slide. If this will.
You need to eliminate to assume.
Yes. Okay, thank you.
Go.
There we go. So you can see this was a gastroschisis. This baby, the bowel was dead, the stomach was necrotic. But in these obvious anomalies, and this is pretty, as I said, graphic, I would take one picture and describe it to the family, ask them if they want us to put it in the memory box, and show it to them, or show them the baby at some point when I bring the baby in to see them. But this is that baby's hands. They are perfect. And no matter what, we can find something that is beautiful. An ear, hair, eyes, feet. I've taken many pictures of the bottoms of feet, and they're beautiful. They're adorable. Because we don't want to concentrate only on the anomaly. And that's the other reason why that poker face, we want to get in there, pick these babies up. We want to hold them. We want to look at them and say, oh, look, this is your baby. So what are some of the characteristics of a comfort care program? Family-centered. I mean, that's, should go without saying. It has to be multidisciplinary. None of us are here 24/7, thank God. We need a break, and especially when we're doing this kind of work, we need to take care of ourselves. So whether it's exercising, whether it's gardening, it's tennis, it's bowling, for me clearly it's eating, whatever it is for you, need to get out more. Whatever it is, we need to do that because we have to refill. We have to be able to come back raring to go. And if we just go, and don't ever take care of ourselves, we will burn ourselves out, and then we can't do this work. So relying on one another, working with each other, helping one another is really absolutely imperative. Open communication. I put this in here because it's always entertaining. Open communications, it's tough. It's very tough. There are so many of us, especially in a big medical center like this. We work different days, we work different hours. It's hard to get everybody together, but it's really crucial. And it's crucial, especially when we're going to speak to families, that we know where we're at. And we're all saying the same kinds of things. The psychological, emotional, and spiritual support should be not only of the family, but of staff as well. So when Linda comes down the hallway, who's one of our chaplains, I am very glad to see her. Because I know I can sit there and say, you know what, Linda, I'm having a lousy day, and this is why. And she's going to hear me. And she may only be able to give me 5 minutes, and she may only be able to pat my back and say, Fran, I feel bad for you. But then I can, again, take that deep breath, turn around, and go back in. We do that with each other. Go in the break room at any time, and you will hear us all debriefing with each other. And we need that. And that's why those spaces should be separate, and we should close the doors, because sometimes we just need to vent, and that's important. Our memorial service, which we do yearly for the babies that have died on the unit, is another, for me, another place where I can kind of regroup and see families. We have families, we've been doing this for 25 years, the bereavements, the memorial service, and I had a mother a few years ago come after maybe 15 years. Her daughter would have been 25, and I took care of her. So the connection was immediate. It was as strong as ever. It was like those 15 years were gone. And you never know what you have done as far as impact to another family. And they may never tell you. I'll share my own personal experience. When my father passed away of lung disease, it's almost 19 years ago. And we got the phone call in the middle of the night, and he was terminal. He was a DNR. And they said, we're going to try and keep him alive for you to get here. And we were on the road. It was my husband, myself, my sister. And I've got this overwhelming feeling of warmth. You can call it whatever you want. I have my own feelings. And I knew he was gone. And we get to the hospital, which is like 15 minutes away, and we walk into the unit. And I got the look that I've unfortunately given to many others. Like, I'm so sorry. I can't talk to you, though. I'm not your nurse. So I knew. My poor sister didn't know. But when we got to the room was cleared of the respirator, the IVs, the suctioning equipment. My father looked pristine. And in his hands were a set of rosary beads that had great significance for him. And I will never forget that picture. And I will be forever grateful to the nurse who did that for me. So we never, ever can know, but know that what we're doing makes a difference. So comfort comes in many forms. We don't have to just look at pain. Babies want to be dry and warm. They want to have a clean diaper. Suctioning is perfectly fine. And even, again, in postpartum, bulb suction. It's great. It doesn't have to be wall suction. We will do nasal cannula on occasion, if we just want to give a baby a little bit of help. The attending orders should include that this is a DNR, that we're not going to give vitamin K, that we're not going to do the eye drops, but we do need orders for that, and we're not going to be doing heel sticks. I can't tell you how many times, and this happens in the NICU really, more than anywhere else, or in TN, where a baby is a DNR and chem strips are being done. It's like, okay, let me start from the beginning. And it's just that gentle reminder, because we're not going to act on any abnormal findings. So there's no need to do them. We clinically can see certain things. If a baby develops seizures, we can give anti-seizure medication. But we don't have to get a 24-hour EEG. Because again, that takes the baby away from the family. That's not what we're trying to do. But we do want the baby to be comfortable. And we want the parents to be comfortable. We had a baby that became a comfort care on our floor. We're going to talk about him later, Henry, who developed seizures. And at a certain point, when he was made DNR, we just treated them clinically. We weren't looking for levels. We weren't doing EEGs. Hydration. So again, as Dr. Paravicini said, you can breast or bottle feed. We can sometimes do just a little syringe in the corner of the mouth. And again, it doesn't have to happen immediately. Babies can go hours. In full-term big fat infants, They go to the breast. What are they getting? Not a lot in the first couple of days, but they are okay. So we don't have to panic. And again, this is where the NICU gets a little crazy. We're like, feed that baby. Feed. Everyone relax, remain calm. So we have to be creative. And you're going to hear from Michelle later speak about how she works with different families and different babies if there's an issue for feeding. Implementing pain and symptom management, again, pacifier, one of the simplest ways to make a baby happy. Stick your finger in their mouth, give them a pacifier, give them the breast. Swaddling, babies like to feel all comfortable. Skin to skin, which I didn't put there and I should have. Feeding also as an analgesic. Suctioning if necessary. And let's start small. Let's start with Tylenol if we really think a baby has some discomfort and see if that works. Easy to get, easy to give. Morphine is the gold standard. We can give Ativan. That would be more for our NICU babies if they're very, very agitated. In our comfort care babies, we have never given morphine or Ativan. Never. Not even Tylenol. And facilitating the family interaction with their baby. If parents can't hold their baby, then we should. So I'll tell you a little bit about another baby that we had several years ago. He was a triplet. The sisters were fine, perfectly normal. He was a hypoplast, a very complicated one, and the family chose to not do surgery. But they also were having some difficulty in being there all the time. They had 2 other girls that they had to take care of. Mom also developed some complications and ended up in the ICU. And the family, mom was one of the oldest in her family, and her youngest siblings did not know about this little guy. So we named him Samuel, and I took care of him many times, and I would come, I would go do another baby, and I would come back and I'd be like, where's the baby? Who has Samuel? Dr. Rubenstein would have Samuel, our ward clerk would have Samuel, the nursing attendant would have Samuel. I found him everywhere. That baby traveled more than most. But the beauty of that, and what it speaks to my heart about, is how we adopted him for them. Grandma came a few times and she fed him. She was very happy. And Mom was having a very hard time, and Grandma was really, really pushing for her to come. And I said to her, just tell her, come and see him. See what good care he's getting. Know that he is safe with us. And luckily, the day that she was discharged, she did come down. Grandma brought her down in the wheelchair. She held him. We opened up the blanket. We counted fingers and toes, talked about who he might look like. And then she went home. And I think he died within a few days of her holding him. And again, the family asked not to be there, but could we be with him? And you know that we were. He died, I think, in my arms, actually. But again, it was this team effort, because I'm not there every day. No one is there every day. And I will also say, Dr. Rubenstein, you wrote in the baby's chart, and it touched me. This precious baby boy was the first sentence, and I loved it. And it was so beautiful to see this recognition in official paperwork, this precious baby boy. So that's what this is about, the recognition of the preciousness that these babies have for all of us. Bathing is another thing. Moms love to bathe their babies. They love to dress them up. They smell good. We keep lotion on the floor as well as the baby wash. If they have baby wash, beautiful. Some moms are a little worried about bathing, but you can do a cute little bed bath with a couple of cups of water or with a pitcher right in her bed. You don't have to go far. Feeding, of course, if possible, and picture taking. Now, some people, they're not great at picture taking, so the more the merrier. The beauty of pictures now, if it doesn't look good, I get rid of it. How great is that? I'm from the age of Polaroids, so this is a big deal. Big deal. Very good thing that we went forward on that. And this is our memory box. So memory boxes, again, are a place for us to collect the memories for this family. So the armband, the thermometer the baby had his temperature taken with, maybe the blanket the baby was wrapped in. And the other thing I'll say about that is sometimes we make assumptions and we make decisions because we think, we know something. So many years ago, we had a couple who were residents, and they had a stillbirth. And at that time, and this is probably going back a good 20 to 25 years, they delivered in Milstein, which is the adult hospital. And they spent time with their baby, but mommy was released that day, and they realized they didn't spend enough time. So they wanted to see the baby, and we brought the baby up from the morgue, and the social worker at the time said, you have to help me with this. So I was like, all right. So they brought a camera, they brought her christening outfit, one of the grandmas came, a brother came, uncle actually, and they spent time in what was then our grieving room, which if I had a picture of it, you would be shocked. That's improved greatly also. But they didn't care. They didn't care. I got this big tub of water and soap, and it was fabulous. And they bathed her. And I gave them, our towels are a little rough, so I give them blankets to dry their babies off with. And when they dried the baby off, she had some sloughing of skin. So here I'm thinking, let's put that in the hamper. The father said, can I have that? I said, you certainly can. So we have to think about those. This touched their baby. That's actually their baby's flesh, DNA right there. And so it meant something for them. Absolutely, I folded that up and put it in the memory box. So the memory box comes with a little outfit, but we also luckily have people that donate outfits and things to us. So if we can, we try to find something that would look sweet on the baby. It comes in Spanish and or English. And inside are places there's a little journal, there's a little condolence card that the staff can sign. There's a place for a footprint. The clay in this, though, I have to tell you, is not so great, and you really have to push to get an imprint. So later you're going to hear from our child life specialist who's going to show how they do the molds with dental alginate. It's a scream. And it's so detailed that parents can, it's three-dimensional then. And we still do footprints and all, but the molds are really something special. And the presentation that they make is just spectacular. There's also a mail preference card so that parents won't get advertisements or free samples of, Pampers. And then there's a card that lists several organizations like Care and Share and Men's that are national support groups. Hospices also offer support groups. Some hospitals offer support groups. So we try to help families know that there's things for after they go home. The other great thing that we have now and that we utilize often is Now I Lay Me Down to Sleep. If you've heard of this organization, they are spectacular. They are professional photographers that volunteer to come and photograph these families and their babies, either before or after they have died, and they do it for free. They are phenomenal. And they are high quality, the kinds of pictures that people pay a lot of money for and just are spectacular. So if you go online and type in Now I Lay Me Down to Sleep, it'll bring you to their website, and you plug in your area code, and they start to look for people to come. They cannot always get here either before a baby dies or even the same day that they die, although they will try. So, and I tell families that we will try desperately. Now, if we know ahead of time, we've had a couple of babies where we've had some time, we've asked them to come, and they've come long before anything's going to happen. And families like those twins. Didn't they do those twins? Those pictures of the twins were done by Now I Lay Me Down to Sleep. The other thing that I didn't mention about comfort care is in thinking outside the box. There are sometimes things that we do that you wouldn't think go along with comfort care, and one baby comes to my mind. Born and ended up in the NICU and was found to have a metabolic disorder that was terminal. And the family's greatest desire was to take this baby home. So he needed to be ventilated, and we trached that baby, taught them how to do trach care, and sent them home. And he lived for 2 weeks. And they were so happy that he died in their home, surrounded by people they love, all of his belongings. That was their wish. Now, that is absolutely the exception to the rule, but it just goes to show sometimes we do have to think outside the box, and we have to meet the needs that each individual family has. So these are what the molds look like. So this is a baby's hands and feet. Typically, she's a trisomy 18, I think. And they wrap it in these beautifully crocheted blankets and put it in a box and give it to the family. So it's just a beautiful presentation, just a beautiful presentation. So I'm going to talk to you about Chaley. Chaley was born in June. She was a 37-week female with trisomy 18, and that was by a maternal blood test. She also had a sacral myelomeningocele. And when she was born, she was floppy and blue and clearly not breathing very, very well. And her physical exam confirmed the findings. We'll see some pictures of her. And she died at 55 minutes of life. But let me tell you, this family packed a lot of living into 55 minutes. She was the 8th child born to this family. They had had a stillbirth previously and came to us because they heard about our comfort care program after the diagnosis. They lived 2.5 hours away. And so mom saw an obstetrician here as well as the obstetrician that had delivered her other kids, because we had to have a plan B in case they couldn't get down here. And I remember the father being very worried about that. Oh no, if we deliver at home, what will we do? And I said, we're going to tell you some of the things that you should ask for. And I said, the one thing I will say to you is if you deliver somewhere else, you are going to have the chance to change culture. And he thought, oh, that's pretty good. So either way, they were prepared. And actually what happened was she came in and she was induced. So this is Chaley meeting her mom and dad. You can see that bossing. Her fingers were, that unusual way that they hold their fingers. She's pretty blue, pretty dusky looking, has a lot of vernix on her, but they thought she was gorgeous, and she is. And this is her from a different angle. Beautiful, sweet face, very sweet. She did have a large defect on her back, not protruding, and I didn't even notice it at first because we wrapped her up, wiped her down, got a new warm towel. So there was a lot of things going on that day. And Bobby's going to talk to us about this later. She was the nurse taking care of mom. So this is Chaley meeting her grandparents. The woman in white is dad's mom, and the other woman is mother's mom. And this father was so good at getting everybody involved. He clearly had thought this out. There's no doubt about it. This is his sister, and the man behind him is his brother-in-law. He's a priest. Now, he was all set to baptize Chaley, but, again, things happen. So they came separately. Mom and dad came the night before, and the children came down in a van with the grandparents and the aunt, the uncle, a cousin, because it's 8 kids. It's a lot of kids to keep track of. So we knew that they knew they wouldn't stay the whole time. So the uncle was downstairs with all the kids and the grandmothers, and the baby was born, and we're in the delivery room, and it's like, she doesn't look that great. So Dr. Parravicini says, I'm going to baptize this baby. And so she takes out the holy water, and she baptizes the baby. And so when the uncle comes up a little bit later, he goes, you baptized the baby. No, that's good. And then he goes to his bag, he goes, but I'm going to confirm her. You guys can't do that. We're like, true, we can't. When I got all this stuff. So, and again, this is exactly what happened. Everybody laughed about it. I mean, it was, I cannot tell you how many times we have laughed with families, even in the prenatal consults, at something. Something comes through. So this is the oldest daughter, and she was just unbelievable. And Marion, who's going to show us, she's our child life expert, this sister held the baby while they did footprint and handprints with all the kids. So each child, because again, imagine trying to figure out what you're going to do with 8 kids. There's not enough room for all those handprints. So what she did was she got a canvas for each kid, each child. They put their handprint and the baby's footprint. So now each of them has their own keepsake from their sister. And I thought, wow, thinking quick, on her feet, good job. It was great. This is the second oldest. And again, this baby doesn't look great, but they are in love with her. This is the next sister. And I have to tell you, these kids were so well behaved. It was remarkable. This is one of the boys. They also, her name is Latin, and they sang a hymn in Latin, the whole family, kids included. And that's when the kids broke down a little bit. So there was crying, and we're okay. Cry to your heart's content. I was crying with them. This is another little guy. And they were just so sweet with her. And this is what you have to love kids. And kids cut to the chase. They don't see so many of the things that we see. And that I love having young kids because they're not impressed with the things that freak us out. They're like, whatever. They come to the NICU, the baby's got CPAP and all these things. They come up, they're like, oh, look at his hand. He's trying to say hello to me. That's all they say. So we have to remember that. We have to kind of help parents know that it's okay. They don't see things the way we see them. This is her twin. They were just ecstatic. And look at how they're all looking at the camera. Like, hello, I'm with my sister. Take my picture. This boy was a riot. He's a redhead, so I have an affinity for him. And he was just like watching everything, smiling, trying to figure out like what we're all about, but he couldn't wait to hold her. And he waited to the end. He did not say one thing. They knew. Like in big families, you have to be kind of organized that way. God bless these mothers and fathers. And they just knew they were each going to get a turn, and they waited patiently, and they got their turns. Right, Bobby? Don't you think they were so, fabulous? Meeting Dr. Paravicini. And me. Look at the kids in the background. Is she going with her, anywhere with her? Don't go far. Now, Mommy bought this christening gown for her on the internet and was so pleased because it fit her perfectly. And it was so, so sweet. The other thing we have are presentation baskets. And this obviously it looks like a wicker basket, and it has a nice little cushiony insert. And because Mom was keeping the baby for a while, and we didn't have a bassinet up there just yet. And she could hold it. And she had a friend who was visiting, and she held it also. And then this picture, I love this picture. I took all of these pictures. I took over 100 pictures that day. Now, some didn't come out great, so I deleted those, but I downloaded everything and sent them to the family. And again, they were so, so happy because even though they did get pictures with Now I Lay Me Down to Sleep, Chaley was alive in these pictures. And they were so grateful that they had them. So again, it's these little things. I mean, we have our phones. It's no problem. So I'll leave you with one last slide. Remember, sometimes the smallest things take up the most room in your heart. Okay? And that's it for me.